The title of the talk, Chronic Neuropathic Pain, to Treat or Not to Treat, that is the question. I'm going to give you an overview of what exactly is neuropathic pain, some terminology associated with it, kind of get briefly into what we think causes the development of neuropathic pain. And then really we'll focus mostly though on treatments, both pharmacologic and surgical. And really hopefully help you all make up your minds whether or not it's worth trying to treat it or not, or what the best treatments are. No financial disclosures. That'll bring us to the first question. The word pain comes from a Latin word pena, which means the following. Okay. Well, the correct answer is D. The word means penalty, and actually there's a Greek root which also means penalty or sometimes payment. Suffering is not a bad guess. Obviously I don't think many of us believe pain is a penalty anymore. We don't think that someone's being punished by the gods or whomever in the form of pain. But I guess that might be part of the reasoning behind the word, the root meaning. So when we think of pain, I'm going to get to neuropathic pain, but first of all, what is pain in our minds? If I came up to someone and gave you a pinch, if it was hard enough, most of you would probably say that it hurts or it's painful or uncomfortable. I looked in one of the Merriam-Webster dictionary. They said it's a sensation of suffering or discomfort, usually caused by illness or disease, injury or illness. But there was more of a definition that we would think of as in medicine as nociceptive pain, which means there's a actual stimulus that is causing some type of damage to the tissues in our bodies, and then that causes the pain nerve fibers to fire and causes pain. The pain that I'm going to be talking about, neuropathic pain, is a little bit different. It's pain caused by a primary problem with the nerves, and I'll get to that definition in a moment here. Just to give you a little idea of the scope of the problem, estimates, these are a little bit old at this point, so the numbers are probably even higher now, but approximately 3.8 million people in the United States have some form of neuropathic pain or another. That equates to anywhere from 3 to 8% prevalence in industrialized nations. So not a majority of people, but still high enough numbers to really make it a medical issue. Again, it's neuropathic pain due to direct damage or abnormal functioning of the nervous system. It can be secondary to a number of causes: infections, diabetes, trauma, stroke, other ones, and I have a more comprehensive list later on. And unfortunately, it's often refractory to our standard therapies right now, and that's leads us to the question in the title of the talk: should we even try to treat it? Just a breakdown of those 3.8 million people. As you can see, the big yellow pie, piece of pie, it's mostly low back pain. And that's just neuropathic. So estimates are that if we took all the people with low back pain, about anywhere between a quarter to a third of them, it's a neuropathic type of pain, meaning there's no mechanical spinal problem causing the pain. Other common causes, peripheral diabetic neuropathy is next on the list, postherpetic neuralgia, cancer-associated pains, pain after spinal cord or spinal cord injury or stroke, and then chronic regional pain syndrome, which I'll touch on a little bit later as well. So again, what is it? Well, there's the definition again. It's the traditional classic definition: pain initiated or caused by a primary lesion or dysfunction in the nervous system. Recently there's been controversy over the definition of it. Some authorities would like to take out the word dysfunction and just really limit it to lesions within the nervous system, and then specifically add in the somatosensory nervous system. Examples again are listed there. Ones I didn't mention earlier include multiple sclerosis, phantom pain after amputations, trigeminal neuralgias, and other. And these can be described in different ways by patients. Some adjectives up there: electric shock-like, numb, shooting, burning, throbbing, pins and needles, stabbing. A couple other that aren't listed there are cold feeling or itchiness as well, can be used to describe the type of pain that they experience. Here's some more medical terminology to describe those things that patients feel. Allodynia is a pain response to something that normally is not painful. So some type of a light touch in someone who has neuropathic type pain can cause a response of pain. And again, can be mechanical, dynamic, thermal. Anesthesia means loss of normal sensation to a region of the body. I'll contrast that with hypoesthesia further down the list, which is just a reduction of normal sensation. Dysesthesia is a spontaneous or evoked unpleasant abnormal sensation, and I contrast that or compare that to paresthesias, which are non-painful, spontaneous abnormal sensations. Hyperalgesia is exaggerated pain response to a noxious stimulus. Hyperpathia is a delayed and sometimes explosive pain response to some stimulus. Phantom pain, pain in part of the body that no longer exists, and referred pain, meaning occurring in a region remote from the actual source of injury. I found a rather comprehensive list of all possible underlying causes of neuropathic pain. I'd like to point out there can be peripheral causes of neuropathic pain, and then also central causes of neuropathic pain, and anywhere along the neuroaxis and peripheral nerve system. I'll bring up our next question. So which of the following are not neuropathic pain, or another way to put it, which of these would be classified as nociceptive pain? Okay, well, the correct answer is all the above. None of those listed are considered neuropathic pain. They're all nociceptive, meaning that it's a pain response to an actual tissue or nerve injury. So post-operative pain, obviously the tissues, nerves are being injured from cutting, tearing, what have you. Sickle cell crisis, it's a ischemic type pain that does release chemical waste products into the tissues which cause pain, and arthritis is an inflammation of the joints. So none of them are primarily a primary lesion of the nerves themselves. I did want to touch briefly on chronic regional pain syndrome. And the reason I put this up here is, I told you there's some controversy on the definition of neuropathic pain. And a lot of people want to take out the word dysfunction of the nervous system. Well, that really leaves chronic regional pain syndrome in a vague category. If you go by the classical definition of neuropathic pain, it's definitely fits within that definition. If you're going according to the newer proposed definition, then it's really not considered neuropathic pain. In my mind, I think I would lump it in there because the treatments for it are very similar to neuropathic pain. And even though there's not a primary lesion within the somatosensory nervous system, it is a nerve. It is a nerve dysfunction that kind of leads to this. This is a table showing the Bucharest criteria for diagnosing chronic regional pain syndrome and their different features, changes in vasomotor activity, which can produce, obviously changes in blood flow to the affected area, which can affect skin color, temperature. Also swelling, pseudomotor, which can also cause swelling and differences in sweating, either more or less sweating. Motor and trophic changes, either reduced movement or weakness, atrophy of muscles, nerve, pressure of the skin, hair, and then pain. People with CRPS can have those allodynia, dysesthesia, all those different responses in the terminology table I showed you earlier. And then really to make the diagnosis, they suggest having 3 or more symptoms and 1 or more signs. In chronic regional pain syndrome, there are currently 2 types described. Type 1, which used to be known as reflex sympathetic dystrophy. I wrote no clear injury. What it means is there's no clear injury to the nerves. It usually is as a consequence of some type of injury or trauma, but not directly to the nerves. The type 2, which another word for that is causalgia, there is a known injury to a nerve, and then people develop this chronic neuropathic pain from it. Even though we know there's an injury to the nerve, even after it seems like the nerve has recovered, there's the mechanism of why some people develop chronic pain is still unknown. And even type 1, the mechanism, it's unclear. Someone can have a trauma sometime in their life and not develop any chronic problems, and then the same person can get an injury later and develop CRPS, and I'm not sure what really predisposes to development and what doesn't from similar types of injuries and even within the same person. So getting away from CRPS specifically, but just into neuropathic pain in general, this has mostly been studied in animal models, where they induce some type of a nerve injury, and then study what changes take place in the cellular and tissue level. Unfortunately, none of them are great models because really animals don't develop these types of pain syndrome spontaneously or after regular trauma. But in the peripheral nervous system, what they've seen is the injured tissue and the nerves associated with them, specifically the sensory nerves, develop a lower threshold to depolarization to the point where they actually get spontaneous or ectopic discharges, or a discharge from a stimuli that normally would not cause a discharge. They also see something called epileptic conduction, and what that means is normally it's something that occurs within the dorsal root ganglion of the section of the peripheral nerves. Normally there's no cross stimulation between nerve fibers. But what we see after injuries are a nerve that's depolarized or sending a stimulus will cause adjacent nerves to also depolarize, again probably due to their lower depolarization threshold, and also there's probably some focal demyelination that's happening to allow their membrane to be more excitable. There are alterations in ion channel expression, and several of them. There's a increase in sodium channels within the cellular membrane, again leading to hypersensitivity and lower threshold for depolarization. Also increases in calcium channels within the cell membrane. And also upregulation of the activity of some potassium chloride co-transporters. And they've even broken this down further into certain types of sodium channels that get expressed. Within the damaged tissues, they've seen collateral sprouting from the sensory nerves that were injured. So they develop new fibers extending to the skin or tissues. That's an observed phenomenon. Not really clear how that contributes to pain, or if it does or not, but it's something that's seen. There's increased sprouting of sympathetic neurons in the dorsal root ganglion. Again, not really clear if this directly contributes to pain, but I guess can kind of explain some of the autonomic changes that take place in some of these neuropathic syndromes, especially like CRPS. And then nociceptor sensitization. Again, the nerves are just more sensitive to stimuli. And then in the central effects, there's central sensitization, so the nerves within the spinal cord are more sensitive to these electrical impulses. The reorganization of the nerve entry into the spinal cord actually gets reorganized. There's some reorganization within the brain cortex, and also changes in inhibitory pathways. So, you can imagine there's, the actual anatomic reorganization in the spinal cord and the brain cortex are permanent changes. So this is just a kind of a diagram showing most of those mechanisms. So, again, this is an animal model where there was an induced transection of the nerve. The sensory nerves, of course, are made of different types of fibers. C fibers, which are usually small, unmyelinated, pain-carrying fibers, and then larger myelinated fibers, which normally carry sensation. And then when these are injured, again, we see changes within the dorsal root ganglion, which is this part of the diagram. This haptic conduction where the nerve fibers cross-talk and depolarize each other, sprouting of new fibers, even at the level of the interface with the central nervous system. There's certain lysophatidic acid, different lipid mediators of things that injure the myelin of the nerves, which probably causes some of the focal demyelination. This is all interesting, but the point is these could be potential drug targets in the future for preventing this type of neuropathic pain from occurring after some type of injury. There's also some interplay with the immune system. There are microglia within the spinal cord, central nervous system, So when there's a nerve injury, again, it's kind of coming from animal models, but there are interferons released within the tissue, other inflammatory markers which regulate the microglia within the nervous system. And then they've identified a certain receptor that some of the microglia express that cause release of brain-derived neurotrophic factor, which then downregulates the potassium chloride cotransporter, which makes cells less sensitive to inhibitory neurotransmitters such as GABA and glycine. And just a blow up of that right side of the diagram, again, the interplay of the injured nerve with the microglia, with the central nervous system and interface. Not all of the microglia express this receptor, but the ones that do can cause this downstream effect of decreased inhibition. Again, potentially a drug target in the future for treating or preventing the development of neuropathic pain. Definitely not an exhaustive study of the mechanisms of development, but I just want to put some ideas out there. So let me switch gears to what can we do to treat neuropathic pain once it has developed. And I'll start off with a question regarding pharmacological therapy. Generally all the following types of agents are indicated for neuropathic pain, except, and there's one there that's not usually a choice. Okay, well, responses all across the board. So the correct answer is SSRIs, serotonin reuptake inhibitors. Of course, there's always an exception. Cymbalta is an SSRI, and that is indicated for post-hepatic neuralgia. But in general, the selective serotonin reuptake inhibitors aren't very good at treating neuropathic pain. Not that these other ones are very good either in all cases, but really they've been a disappointment. Selective norepinephrine serotonin reuptake inhibitors actually are a bit effective, but not the selective serotonin. The other ones are used for different types of neuropathic pain. Again, here's a list of them. Opioids, although they're usually not a first line choice for most treating physicians, mostly because of the side effects and tolerance that can develop. NSAIDs are usually a first line drug of choice, although they don't really work all that great for neuropathic pain. Calcium channel blockers, the gabapentin and pregabalin, can increase inhibition of the nerve, the pain nerve, the nerves that carry pain within the central nervous system. Obviously, these are a first-line choice for many types of neuropathic pain. Tricyclic antidepressants are another good choice as they inhibit those pain nerves. SNRIs, which I mentioned. Anticonvulsants, gabapentin and pregabalin fall into that category, but also things like carbamazepine, lamotrigine mostly for trigeminal neuralgia. NMDA antagonists, ketamine, dextromethorphan are two examples where they probably increase the effectiveness of opioid receptors to both endogenous endorphins as well as administered opioids, and local anesthetics. And there's an idea that we can kind of tailor some of these to the condition. for diabetic, painful diabetic neuropathy. Usually the gabapentin, pregabalin, Cymbalta, tricyclics are the first line drugs of choice, followed by tramadol or opioids. For post-herpetic neuralgia, kind of a similar type of breakdown. Also added in there are lidocaine patches. Trigeminal neuralgia, I mentioned, usually anticonvulsant type drugs are first line choice for effectiveness. And then for chronic regional pain syndrome, some studies have shown that in the early stages of it, anti-inflammatories, either steroids or non-steroidal, can be effective for treating it or potentially preventing it from becoming more severe. Also, there's some literature that bisphosphonates can be effective, and then the rest are kind of similar there. There are also some immunomodulatory type medications that may be helpful in chronic regional pain syndrome. That's just another list specifically for CRPS. It says there's really no published evidence that the drugs on the right-hand side work, but they're definitely worth considering since it is a tough condition to treat. That's kind of the standard classical approach to things. There is some evidence coming out that it may be worthwhile to use multiple different categories of agents from the start to treat neuropathic pain, and that may be more effective and synergistic than just using the individual agents alone. So mostly usually one of the like gabapentin or pregabalin along with opioids. And then finally, one last comment about pharmacological therapy. Those are things that can work for some people. Unfortunately, there's no cure for neuropathic pain. None of them completely relieve it. In people who are effectively treated with pharmacologic agents, the goal is to reduce the amount of pain, not completely eliminate it. And really, maybe the primary goal is to increase function. Unfortunately, the rates of achieving those goals are probably less than 50% with most of those pharmacological treatments. So there are also surgical options, mainly neurostimulation these days. There is tradition also of nerve ablation type procedures, and I'm not sure most of those are being done anymore. I don't have any personal experience with doing any of those, except about reading them and reading about them in textbooks. But let me start off with a question about stimulation. Post-stroke pain can be treated with the type of stimulation, namely surface cortical stimulation of part of the brain. And, which one of these areas might it be? Well, that's a good guess by most people, but unfortunately, the correct answer is C. So yeah, you wouldn't think, well, this person's having pain, that's a sensation. You think target the sensory cortex. Well, no, actually targeting the motor cortex can actually reduce some of the pain. Really the exact mechanism of that is not entirely clear, except that there obviously is some interplay between the motor and sensory portions of the brain. They're not completely in isolation. It's probably some descending inhibition type control or modulation of the ascending fibers is the best guess right now. So the stimulation of the somatosensory cortex has been tried. Unfortunately, it usually produces unpleasant sensations that really aren't very well tolerated. So there are different parts of the nervous system that can be targeted with stimulation. The spinal cord is probably one of the more common areas, especially for neuropathic pain, but also there have been stimulators for peripheral nerve. These probably the one most in widespread use right now is for occipital neuralgia, to target the occipital nerve. The sacral nerve roots can be targeted for stimulation, either the ventral motor nerve roots for things like bladder dysfunction, neurogenic bladder, or erectile dysfunction in persons with spinal cord injury, or the sensory sacral nerve roots for people with interstitial cystitis or urge incontinence. Although the evidence for those things are not very. There's not very much good evidence. Most of them are case reports or series. Deep brain stimulation for pain, including thalamic stimulation for neuropathic type pain, and cortical stimulation, which I talked about in that question at the beginning. So really, of these areas that are targeted for stimulation, the ones that have the most evidence are the spinal cord stimulation and the deep brain stimulation. But even for spinal cord stimulation, there are really only a couple of randomized controlled trials, and one for post-laminectomy syndrome and one for chronic regional pain syndrome. And in those randomized control trials, the success rate measured as reduction of pain by 50% or greater was anywhere from 65 to 70%. It was between 60 and 70%, about 60 to 65% for post-laminectomy syndrome, and between 65 and 70% for CRPS. So maybe a little bit better than pharmacological treatment, although the problem with stimulation is that you incur the risks of surgery as well as the cost of implanting these devices. How do they work? We think they increase release of inhibitory neurotransmitters and decrease the release of excitatory neurotransmitters within the central nervous system. There used to be this thinking that it closed the gate. If any of you heard the gate control theory of pain, we think probably not, because they're not effective for nociceptive type pain. But just to show a schematic of that, the gate control theory is that the pain fibers and the normal touch sensation fibers both synapse on the same central nervous system pain propagators. If you stimulate the pain fiber alone, it stimulates the pain conveyor and inhibits the interneuron, which inhibits the transmission. If you stimulate both simultaneously, then the touch fibers will actually stimulate the interneuron, which inhibits the central pain conveyor, and the overall effect is that it will block the pain transmission. So anyway, it probably does some of this to some extent, and in fact this is probably the basis for the efficacy of the TENS unit, because it stimulates the somatosensory fibers more than the pain fibers. But probably not all that's going on with spinal cord stimulation. So yeah, before I get to the last question, there was one article in my citations, and it actually included some quotes from people who have neuropathic pain. I just want to just paraphrase some of these, but just to give you an idea of the way it affects patients. There was a 34-year-old man with T10 paraplegia. He said, not all quads and paras have complete injuries. We do have pain. At worst, it starts like a pressure and then progresses into a burning heat that you can't stop to the point where you don't want to live anymore. He said, I haven't had a full night's sleep in about 10 years. Don't forget that chronic pain destroys relationships. A 53-year-old man with painful diabetic neuropathy said, the pain in my hands is so bad sometimes it feels like my hands are stuffed too tightly into the skin and they're going to explode. It keeps me awake at night. My feet don't feel like feet, they feel like numb blocks, or the other half the time they're burning. I guess you can tell that my mood is affected by this pain. A 56-year-old woman with multiple sclerosis. When I try to move sometimes, it's like someone is jabbing me with a hot poker. My muscles jump and it feels like the nerves are being shocked. You know this is just miserable. So here's the last question. Should chronic neuropathic pain be treated? Well, I mean, this is really an opinion poll more than one correct answer. I'm kind of, in my mind, leaning toward B. You know, one of the things that we need to develop are some type of predictor about who's going to respond to what types of treatments, and that's something that we don't have right now because the mechanisms of neuropathic pain aren't quite fully understood. References I used. Welcome to any questions, but probably have to keep them brief.